A very good morning to you. Many thanks for joining us this morning. My name is Lillian Muli, sitting in for Sarfine this morning. And our topic of discussion on this health segment is arthritis. Joining me in studio is Dr. Michael Maru. He's a consultant orthopedic surgeon, and he'll be walking us through the prevalence as well as the management of arthritis. Good morning.
Good morning.
Thank you so much for being with us. Dr. I want to begin with the fact that arthritis has commonly been known as the old people's disease. Ugonjwa ya wazee. It's been known as ugonjwa ya baridi kuingia mwilini, that is cold getting into your bones. But just break down for us and to us what exactly arthritis is and what the most common types seen in Kenya are.
Okay, thank you for having me here today. My name is Dr. Michael Maru. I'm a consultant orthopedic surgeon based at Nairobi Spine and Orthopedic Center. I also consult at PC Kikuyu Hospital and other hospitals around Nairobi. I hope that, first of all, I say welcome to our viewers. I hope that this session will give some light into understanding arthritis. Arthritis in itself, if I may define it, is a word from Greek. It's called arthron. Arthron stands for joint, and itis stands for inflammation. So arthritis is inflammation of joints. When you mention about it's more commoner in the older population, we'll come through that. But the first thing I want to explain to the audience is that arthritis is about joints, not about bones. Because that's a very confusing term when people come and say, I'm having bone aches. Bone ache is a different story from arthritis.
Yeah, well, so and we need to get down to the common types seen in Kenya because when we talk about arthritis, it is broad. Yes. We've seen people talk about different types and their manifestation. So walk us through that. Yes,
there are more than 100 types of arthritis, but the common ones, I would classify them into 5 groups. The first one is called osteoarthritis, and osteoarthritis is a condition that we call wear and tear. It comes with age, commonly from the age of 40 onwards. We know that women are affected more than men. And I know you'll ask me why, but that question comes up all the time. Yeah. It's because early on in life, estrogen in women protects them from getting arthritis. But after menopause, we know that one of the contributing factors to getting arthritis is a reduction in estrogen. Secondly, we know that women seek medical attention more than men, and therefore, effectively, the incidences of arthritis are picked up more in women than men. Then the second type of arthritis is called rheumatoid arthritis, which is genetically linked, and it's an inherited condition. It causes inflammation of joints. It can start at any age, but commonly from the second decade onwards. The third type of arthritis is called septic arthritis. Septic arthritis is where pus gets into the joint and causes severe joint inflammation. It comes, usually it's a pediatric condition from the age of, even from the age of 1 to about the age of 16. The kids just get inflammation in their joints, and when you put a needle in there, find that there's pus. So that is called septic arthritis. The third type of arthritis, which we are seeing much more commonly than we ever used to see, is what we call post-traumatic arthritis. Post-traumatic arthritis occurs when you get an injury to a joint, and subsequently the damage to the joint results in arthritis. We are seeing it more commonly than before because of road traffic accidents, and especially motorbike accident. And I must say the knee is a commonly affected joint, because when they make contact with another vehicle or the ground, the knee is the one that suffers a lot. So we are seeing arthritis of the knee at a younger age than we used to see because of the increased accident. The fifth type of arthritis, a phenotype, is gout arthritis. We'll talk about that because it's commonly affecting the middle age. Yeah. I mean, middle age and middle class. Yes. I
want to zero in on some of the more common types. You talk about post-traumatic being the most common and related to injuries, accidents, and what have you. But when we talk about the rheumatoid and the gout, let's first start with the gout, which is the one that you mentioned last.
Yes.
Basically, a lot of talk around gout, and I know this is a topic topic perhaps that would be a standalone on its own, but in the context of arthritis and talking about gout more commonly being associated with men,
yes.
Please walk us through how this arthritis manifests itself and in what particular gender.
Yes, gout is a condition that affects the joints, synovial joints. It's more common in men than women. Once again, the hormone estrogen protects women from getting this condition to an extent, but much more so, men are affected more commonly because it's a lifestyle disease. Lifestyle disease commonly affecting middle class and above because a combination of alcohol intake and eating red meat. And then you have that, some people have genetic predisposition. So when they do eat meat, meat has things called pyrimidines and purines that are usually broken down to uric acid. And when they consume alcohol, that alcohol, when it gets the kidney, alcohol gets preferential removal from the body, and uric acid is retained. The retention of uric acid, therefore, results in a situation where it has to be deposited somewhere. It's usually deposited, most commonly, the farthest part of the body, because it needs to be a lower temperature so that those uric acid can crystallize. That process results in severe pain in the big toe, sometimes the foot, pain in the foot, and also the elbows. So that's the reason why consuming large amounts of alcohol combined with red meat. So we advise them to stop, either stop taking alcohol or reduce alcohol and also reduce red meat and go into white meat like fish or chicken, and then from there lifestyle modifications.
Right. Now, we've talked about a lot of issues from gender to hormonal imbalance, injuries. But in this country, and in terms of health-seeking behavior, of course, always been a concern that women have better health-seeking behavior. But in terms of this being a health concern in Kenya, how big a reality is this in terms of the prevalence and in terms of its manifestation over the years? Previously, of course, like I said earlier, it had been associated more with the older population. But now looking at the general scope of affairs in the country in terms of prevalence, where are we at? Right.
I'll put it in a perspective. Let's start with globally. Globally, we know that the incidence of arthritis is more than 300 million people are living, 300 to 500 million people are living with arthritis. That's a staggering 1 in 5. It tells you how common that is. In fact, arthritis is the second commonest cause of disability, second to mental health disorders. When you talk about the cost, in terms of cost of managing arthritis, it's the highest. When we look at the point where we've gotten to doing joint replacement, we know that the numbers are going up, and it's expected that in the next 2 decades, 1 in 4 people have arthritis. We are finding it the same kind of results here in Kenya, locally. People living in colder areas increasingly complain of pain in their joints. They tend to, they do have arthritis, but it tends to flare up in the colder season because of the circulation around the joints and the nerve response. So they call, especially the highlands, especially Mount Kenya region, Meru, Nyandarua, and even other areas in Kenya, they tend to complain about arthritis when it's cold. That's what I would say. Yeah. Right.
Now, in terms of its presentation, does arthritis present differently to different people? And this is not specific to age or gender in terms of its presentation, because, for instance, you're talking about flare-ups in the colder regions of the country, but somebody could be having a similar condition in Mombasa, which is pretty humid, and perhaps not have an extreme an experience in terms of flare-ups. And so in terms of moderate to mild to extreme cases, what are we looking at? And just bringing in the management in terms of diagnosis. Do we have adequate facilities, adequate professionals? You're an orthopedic surgeon, but in terms of the awareness, the diagnosis, but before that, just the general sense of how it presents itself in different people.
Yes, before we get to the presentation, I brought in some slides here, and you allow me to go through just one or two regarding the knee. The knee joint is one joint that is affected by arthritis.
Right.
It's a dear joint to me because of my name. So I'll talk about the knee joint one way or the other.
Because of your name?
Yes, yes, yes.
Which is?
means the knee.
Oh, the knee.
Yes.
Okay.
So right there you see a picture there of just the anatomy of the knee.
Yes.
I went to the picture before that. I just show the anatomy. It shows the cartilage. That area written the cartilage. That's how the knee looks like. And the blue area contains a very thin layer of articular cartilage.
So that's the picture before that you were talking about? Yeah.
Yes, the blue area there. That's the anatomy of the knee. That blue area is what protects the joint from getting arthritis. It's called the articular cartilage. And among the cells in the body that can regenerate, other than we know that there are 3 cells that don't regenerate: the cardiac cells, the neuron cells, and also the skeletal muscle. But after that, the articular cartilage has limited regeneration capacity. So once it's gone, it's gone. The next picture, please. Just showing the cartilage again, you progress to the next picture. So once that area starts degenerating, that's what you get in the picture on my right side, the cartilage loss. And then the bone is exposed. Bone, once it gets exposed, you get friction. The friction from the bone above and the friction from the bone below is what we call arthritis. And that is what causes the pain. So one of the presenting features, as you asked me about the presentation, there are 3 key things: pain, swelling, because that friction produces fluid called effusion, and limited function. Limited function is where they are unable to, patients come in and say, I'm unable to go up the stairs, I cannot sit down on a toilet, and activities of daily living become very difficult. Right. So that is where we are in terms of presentation. And then the fourth presentation is usually deformity. So you just see, so we start getting deformity, and you see people walking in the streets with what you call knock knees. Yes. And then the next picture you get to see there is bow legs. So when you see those deformities, that is now advanced arthritis. And so I've said loss of function, pain, swelling, and deformity.
Let's talk about the deformity. When you talk about the knocked knees, when you talk about the bow legs, this is somebody ideally that progressively had this condition and it was not managed, or how does it get to this place?
Yes, when now come to diagnosis, one of the things that limits making that diagnosis is the point of contact of the patient and the healthcare provider. It's unfortunate that we do have a lot of orthopedic surgeons, but we still need more orthopedic surgeons, especially in the periphery. They'll make contact with maybe someone who's not aware that this is arthritis. They'll go in and get medication. And then the other thing is over-the-counter prescriptions. We have a lot of that here in Kenya. So by the time that patient is getting to the orthopedic surgeon, they already have developed arthritis. So one of the issues that we face is late diagnosis of arthritis in our setup.
Right. Now, so talking about late diagnosis, perhaps where we should go back to is the background in terms of early signs that somebody should look out for. And because of the misinformation, perhaps even just from your own home, certain symptoms, you might think that, I've just been drinking a lot, this is gout, or if it's a child, if it's perhaps a pediatric case, a lot of parents might dismiss that, or even medics might dismiss that as something else entirely. So in terms of general symptoms, general signs that people should be on the lookout for that could eventually lead to an arthritis diagnosis?
Yes, that's a very good question. I'll start with the kids, especially the children here. With kids, if a child wakes up in the morning and cannot move a joint and there's no history of injury, you should be concerned as a parent, because that is a high indication that that joint could either be having septic arthritis, and that is an emergency. So inability to move a limb, painful, and also swelling. So that is what I would expect, that if you as a parent, you see that, take that patient to a health facility. The older population, once again, the earliest sign of arthritis is symptom of arthritis is pain. And then the other signs we see is swelling, and we see deformity. We don't want you to come in when you have deformity. Start at the point where there's pain and swelling. Get to see an orthopedic surgeon. Yes.
In terms of, so you talked about the knee, and you walked us through, the loss of function of the limb and what have you. But this was more concentrated towards the knee area. We know old wives' tales tell us that, if you crack your knuckles, there's a lot of things around joints, and these also being joints, the finger area, the elbow as well. So what other parts of the body can it manifest itself in terms of joint pain, joint inflammation?
Absolutely. I talked about the knee as just a case study. I chose the knee, but all the other joints can get affected. Just to put it again into perspective, we have 206 bones in the body, and more than 360 joints in the body. And most of those joints are synovial joints. Any synovial joint can get affected by arthritis. So the hip joint, the shoulder, elbow, the same way as the knee. And what I talked about the knee can happen to any of those joints as per the sequence.
Yeah. Talk to us about what you have on the table and what this is in terms of, is it for joint replacement? Is it what intervention would necessitate the use of these items that we have here in studio, and what are they?
Yes, we've gone through the steps, and we've mentioned about the presentation, the clinical presentation, as well as what you expect as a doctor from when you see something in a patient. As a doctor, you should know this is arthritis, but we need to confirm that this is arthritis. So what diagnostic methods are used? One of them is X-ray. I brought a picture of the X-ray. It's on the screen there. Okay. It shows the knee joint, a normal knee joint, and on the right side shows an abnormal knee joint that has arthritis. These questions come all the time at the clinic. How do you know this is arthritis? We know that space there between the two bones is what I said is the articular cartilage and the tissues that protect that knee. The minute you start getting wear and tear, that space disappears, and then bone sits on bone. That is what we call now end-stage arthritis. That happens in all the joints. So early on in the diagnosis is X-rays. Sometimes you may require to do other modalities like MRI, but a simple X-ray gives that information. In children where you're suspecting septic arthritis, or even gout or other, you may need to do blood tests. Like in rheumatoid arthritis, you do blood tests to confirm if indeed it's rheumatoid. In gout, you do uric acid levels. So you need to make contact with an orthopedic surgeon or a healthcare provider who understands that. Then you move on now to saying, how do you manage this? Management of arthritis, it depends on the stage of arthritis. So you have early stage, you have moderate, and then you have severe. In early stage, and that's why I want us to address this more, because you want to get them at the preventive level, not at the treatment level. Early stage, it's medication, so you give some medication to reduce the pain. We also advise that you do physiotherapy, keep the joint moving. And the third thing that's so important is weight management. We know that obesity has direct correlation with arthritis, and is actually dose dependent. The heavier one is, the higher the risk of arthritis. So that is a lifestyle modification that can help prevent the progression of arthritis.
I want to talk about that in terms of lifestyle and arthritis and the link. The heavier you are, the more prone you are to arthritis. Please explain what that means exactly.
It means the human body is made, and the cartilage is made to carry a certain weight to maintain that joint in its correct position. The minute excessive force goes through that articular cartilage, the articular cartilage cannot survive, and eventually start getting degradation of the articular cartilage. That
you're too heavy for you can't support your own weight.
Yes, precisely. The cells just take so much force that eventually start get wear and tear.
Right.
In addition, the heavier you are, the less active you're likely to be. And these joints, as I say, keep joints moving. So we have to address it at the preventive level and say, maintain a level of exercise, and also watch the weight, and also diet. Yeah.
Away from the weight, because we're talking about lifestyle, we talked about the gout, that also being lifestyle. And we'll come back to this, which was my previous question. We talked about gout, another lifestyle-related issue as well, with the alcohol and the intake of the red meat. But for menopausal women, we need to go back there in terms of menopausal women and the risks that lie therein. You're getting into premenopause or into menopause, the hormonal levels changing, the estrogen that you talked about. So walk a woman that is premenopausal, postmenopausal on her lifestyle and what women really, as they age or get into this stage of menopause, should put into account as we talk about arthritis and avoiding it entirely?
Yes, a lot of women come to the clinic and say, about 40, they think that they're approaching menopause. They say, should I start taking supplements? And that's a common question. I would say, if you're below 40 and you're balanced diet, you're active in terms of physically active, I don't think there's any need to take supplements prophylactically, because we don't recommend that. You'd rather go and have blood tests. If your calcium is low, then get it addressed. Vitamin D is a big issue too. So menopausal period is also about bone density. So some of them come in and with bone aches or bone pains, you say you do postmenopausal, you do a DEXA scan, find that their bone density is low. Those ones you supplement. So far from that, about the joints, postmenopausal, if they're having joint aches, then they need to make contact with the doctor, see if there's any need for supplementation. I think that is recommended postmenopausal.
Right, and talking about disability, Daktari, when we talk about management and prevention, and you talked about the extreme cases of arthritis, and we've gone through those slides of the knocked knees, the bow legs, and really we see a lot of these cases, and you know, curiosity has you thinking, how did this person, you know, get this way? Is it genetic? Were they born this way? Some people are actually born with these knocked knees. It's something that manifests itself right from birth. So let's talk about disability being, you know, a real reality for persons with arthritis if it is not checked and addressed early enough.
Yes, we'll talk about that disability and then also finalize with the implants. The disability, when it happens in a younger age, it's not connected to arthritis at all. We know that some kids can develop bow legs or even knock knees as they grow. And in fact, it's a normal curve up to the age of 5. So you get kids coming in at about 3, they have bow legs. The parents are worried that this is going to go to adulthood. No. We normally observe them along the way. If we need supplementation, calcium and vitamin D, if it's rickets, we treat it. So that is a different story from arthritis. Genetic-wise, yes, the genes that you inherit from your parents can also make you develop bow legs and knock knees.
Yeah.
So the knock knees I showed the other picture were purely due to wear and tear in the joint, and also the bow legs about wear and tear.
Okay.
So I said that at some point in the management of arthritis, it gets to moderate, where you've tried supplements, you've tried medication, and there's still pain. The joint is still getting worn out. There's some procedures that can be done to preserve that joint, such as arthroscopy to reduce the inflammation and also to clear up the debris. So that is moderate arthritis. And still continue with supplementation and also medication. But it gets to a point where you've tried medication, you have tried losing weight, and now it's end-stage arthritis, just like that picture there. In which case now we say severe arthritis. That's the time we talk about joint replacement procedures. It can be partial joint replacement or full.
Yeah.
Like the implant I brought here for demonstration is a knee replacement implant. This is what we normally call total knee replacement. It is metal on plastic and then metal. This metal is made of, they're usually made of stainless steel or titanium, and even more modern now, cobalt chromium, where the metal is highly polished. On the back side of it, you prepare the bone just like there. Then you put cement at the back of this implant and hold it onto the bone. This is cement that is called bone cement, not building cement. Then you hold it there for about 10 minutes, and that holds the implant in place. Then at the bottom, once again, you prepare this implant and then put it in, and eventually this is what you get. So eventually, when you get movement, this is the kind of movement that occurs in the knee joint, meaning that this bone will never touch the other bone again, and that's how the pain goes away.
Right.
That is what is called total knee replacement.
So when you talk about implants such as these, in terms of full use of the limb, what interventions would be necessary after this surgical procedure to ensure that, you know, because this is new to the person. This is a foreign object, a foreign thing in somebody's body that perhaps they're not accustomed to. So in terms of, you know, the full use of that limb, in terms of managing it, in terms of even possible infections, this of course being steel or metal, what interventions aside from just the surgical procedure are needed post-surgery?
That process starts from the minute you make contact with the patient. You do informed consent, so they understand that this is foreign material that is going into the body. This has been studied for years and years, so it's not something that will react to the body. Some people say that they're allergic to metal.
Yeah.
This is not the kind of metal that they get allergic to. The allergy in metal is usually due to cheap metal like nickel. This has been studied all these years. Some people get infection. They get past and they think it's allergy to... It's not allergy. That is infection. So infection can occur, and that is about surgical etiquette of the team, the surgeon, the entire theater team. So they must take precautions to ensure that this implant doesn't get infected. So you must develop a system and a team that you work with that helps you to achieve this kind of results. Secondly, in terms of function, we know that we are doing this not for you to get back to that top level, like running. We do it to minimize pain and improve function. Those are the key things, the reason why we do joint replacement. So the patient must understand that I might not be able to do some of the things I used to do when I was younger, but at least I'll have a better quality of life, there'll be less pain, and we'll better function.
What about posture when we talk about a possible limp? Does this affect, you know, how somebody would walk their normal walk? Would you need perhaps a walking aid? Would you have a slight limp that is visible to, you know?
Yeah, but initially after the surgery, first of all, we talked about deformities. This is the only way you correct those deformities, the bow legs and the knock knees. Because when doing the procedure, there are ways of aligning that knee to correct that deformity. So they do achieve normal gait. But it takes about 2 weeks. They're using crutches, they do physiotherapy. And usually the procedure is usually one, depending on where you get it done and who does it, it can be between 1 hour to 2 hours. And most patients stay in hospital for about 3 days, and they use crutches for about 2 weeks to 3 weeks. And by 6 weeks, most of them you'd expect should be walking normally.
We have some questions coming in from our viewers, but before we take that, the question of the cost of treatment, is this affordable for the ordinary Kenyan? In terms of, I mean, and we know that there's supposed to be some intervention in terms of medical aid from insurance, from the government, and what have you. But in terms of the affordability of management and treatment in such cases, how easily can a Kenyan from perhaps any walk of life afford this treatment?
Yes, I would say it's affordable in one way and can also be very expensive in another way. I've said that because the cost of doing this procedure can range between a figure like 300 to 500,000 total cost, depending on the institution that this is done and the implant that is used. Because you have implants coming from out and from the West, and others coming from India and China. But on average, this has become affordable one way or the other. And I'm saying that because with the SHA now being available in most institutions, they do contribute a heavy amount towards this procedure, and then the patients are able to top up and get them done with it. And some institutions, this can be fully covered by SHA. So it is affordable in that way. But also those who have insurances and wish them to be done in private institutions, they're still able to afford, and they top up from what they are given by SHA.
Well, let's take your questions to Daktari as we talk arthritis this morning. Remember, we are talking about arthritis and its management and intervention. Good morning, Lillian. Please ask Daktari, my mom has pain on the back side of the waist and it started with the knee. Could that be arthritis? Let's take another one. Good morning, Daktari. What treatment would you recommend for rheumatoid arthritis affecting my ankle and fingers? I'm only 36 years old. Before we take the other question, let's address this one and the previous one. This one is about somebody who's 36 years old. They say it's rheumatoid arthritis and it's affecting their ankle and fingers. So what treatment would you recommend for that?
Thank you for that question. Rheumatoid arthritis at the age of 36 is a condition that should be managed carefully, and should be managed by a rheumatologist, perhaps not even an orthopedic surgeon, because the early treatment of rheumatoid arthritis is medical. And now there are so many advances in terms of the medications that can be used for rheumatoid arthritis. So I would say make contact with a rheumatologist so that you can get the best treatment medical-wise. But if it got to the point where it requires surgical intervention, then that's when they get to see an orthopedic surgeon.
The previous question of the lady talking about her mom having lower back pain and how to manage that.
Yes.
Or whether it could be. Perhaps we could take a look at that question again. The first question, Ibra. Yes, let's take a look at that one again. There we go. Please ask Daktari, my mom has pain on the back side of the waist and it started with the knee. Could that be arthritis?
Yes, it could well be arthritis because I said you can have arthritis in the knee and you can also have arthritis in any part of the body that has synovial joints. And we know that there are joints in the back that have synovial joints. So those ones can also be affected by arthritis. But more commonly though, in the lower back, that's a patient who needs to see a doctor so that they can also check, could it be a disc issue? Because back pain can also be brought by other issues other than arthritis. And in fact, depending on the age, it's most likely a disc issue. So see an orthopedic doctor and get an MRI scan to differentiate between the two.
Yeah, and let's take the third question. We have another question coming in from our viewers. And this is from Alex. Lillian, I've noticed that my foot joints make a popping sound when I walk. Do you have any idea what could be causing this? So that popping sound on the foot, others actually talk about the knee as well making a popping sound. But let's talk into Alex's case on the popping sound that his foot joints make.
Yes, a lot of people have things that we call cracking sounds coming from their joints. And in fact, some of them are able to demonstrate them using their fingers. Cracking sound coming from a joint is a ligament stretching. It is not usually anything to do with the joint. And as long as it's not painful, ignore it, because people are different one way or the other. But when it's kind of painful, then you need to see a doctor to check, could it be an issue with that joint.
Okay, and of course, I had earlier spoken about some of the misconceptions, the old wives' tales. We were told growing up not to crack our knuckles because they'll end up remaining that way. You know, there are people who are able to crack their toes as well. Yes. So some of the misconceptions around arthritis and really the real facts around its manifestation and what really cannot be, such as that popping sound, which you say is probably nothing to worry about. So just allaying some of those fears based on things we were told perhaps growing up.
Yes, cracking sounds and popping sounds are basically of no concern when it comes to arthritis. And I must say we all have our genetic predisposition, so we are not the same. So I would say don't worry about that. But when you do it and it becomes painful, or even it happens where some people say, every time I get up from sitting position, my knee produces some crunching sound, crunching feeling, and also cracking sounds and also pain, then you need to see a doctor, because that could be a condition that affects the kneecap, and it's called chondromalacia patella. So those are the kind of issues that should be addressed now by a doctor, but not just when you're walking, a cracking sound has no bearing to arthritis.
And you know, Daktari, talking about a very diverse audience, we have people watching us from far-flung areas of the country, perhaps people who might not find some of these services, such as those of an orthopedic surgeon, readily available unless they come all the way perhaps to the capital city. So in terms of treatment options available locally for arthritis patients, we talked about the cost of managing it being perhaps not as strenuous as would have previously been. In terms of treatment options, people who do not have the access, we know that trained medical personnel in some of the far-flung areas remains as an issue, skilled personnel, and therefore treatment options, perhaps for somebody who is very far off, somewhere in Turkana, somewhere in God knows where, very far away from perhaps a level 4 hospital, perhaps from a private hospital that has an orthopedic surgeon. What options would you say would be the first go-to for perhaps somebody who's dealing with a parent who's showing such signs, could be easily be arthritis from what they've observed? So first point of contact in terms of seeking intervention.
Okay, luckily, orthopedic training has expanded significantly in the last 10 years, and we have a lot of orthopedic surgeons even covering areas that previously were not covered. I think from now, from level 4, level 5, most of those hospitals have at least one orthopedic surgeon. And in that kind of a setup, the first contact will be a clinical officer. So we've been doing awareness courses to enlighten the clinical officers on what to pick up in terms of arthritis and then refer to the orthopedic surgeon. Most of these procedures are now available in all county hospitals, referral hospitals. I would say referral hospitals and private institutions. And I said there are orthopedic surgeons now in most of the referral hospitals. So that's a very good thing. And we are still continuing to train more to ensure that there's enough coverage in the entire country.
Yeah. Now, managing arthritis for a patient who has had it, you know, you're in a family situation, you know that your loved one has arthritis, so managing it right from home in terms of away from the treatment, you know, perhaps managing the pain, the inflammation, but just managing it right from the home. What would you advise?
First of all is to make the right diagnosis, because if I say there's a lot of over-the-counter prescription, they come and tell you, I've been having joint aches for the last 5 years. Every time it flares up, I normally go to the shop, buy some paracetamol and the pain setters. That in itself is something that needs to change, because unless you make that diagnosis, you'll not do the right management. So we need to encourage and make them aware that if pain persists in a joint despite taking any medication, then seek medical help. And the simplest thing is usually an X-ray, especially for those older patients. So they're able to get X-rays because X-rays are available locally. And from there, then seek attention from an orthopedic surgeon if needed. Managing from home is good for mild and moderate arthritis, but when it gets to severe arthritis, then that needs an orthopedic surgeon. I was just about to mention about the hip, just to show the other people. This is what is called a total hip replacement, because these are the two operations that we do commonly. Once again, this is a stem. So you open up the hip joint at the stem. We put this in the medullary canal and hold it with cement, or sometimes you put the one that doesn't have cement. This is called the ball, and this is called the stem. And then in the socket, we put in this plastic socket, and this is now how the hip operates. Once again, it's held with bone cement to stay in place, and then this is a kind of articulation that occurs. That in itself helps get rid of the pain, because once again, the bone will never touch the other bone again. That is what is called total hip replacement.
Somebody is asking about these implants, Daktari, in terms of once you have this implant, whether it's the hip replacement or the knee replacement, are these implants that you can live a full, healthy life with? Will there need to be successive or further surgeries going forward based on the wear and tear of these implants? Is this something that you can live a full, healthy life with?
Yes, the success rate for total hip replacement globally is 90%. So 9 out of 10 people will be happy with this procedure. Knee is about 85%, because the knee has other issues, especially the anterior knee pain. But for the hip, again, more successful than knee. It's because we say the two things that we're aiming for is reduction of pain and better function. Yeah. We expect that to last at least 10, 15, in fact, even more, go up to 20 years. Because of course, there are now a lot of research going on to get implants that perhaps will last longer. But the main issue was the cement. It used to loosen over a period of time, in which case then you come back, we revise the implant and give you another 15 years. That's why we encourage that you retain your native knee for as long as you can, so that if you get about the age of 75, between 70 and 80, you get this replacement, it sees you your lifetime. But sometimes you have to do it earlier than that due to post-traumatic osteoarthritis. So this one's after about 15 years, 20 years, expect a revision. Somebody
here is reacting to this, and they're saying that the use of an implant progressively made the mobility of the limb worse over time. I suspect this was a procedure that was done years back, and progressively this person has now developed an obvious disability based on the implant that was done on them. This was a hip replacement, according to a viewer here. In such cases, what is the intervention that would be needed?
We would have to look at case-by-case basis, but for sure it sounds like an implant that was put in perhaps was functional for a period of time. I said expect any period between 10 and 20 years, it will loosen.
Yeah.
And that's a natural cause of that implant, and so that may require revision. But remember, when the days pass, the longevity of this implant can be quite low, because past makes it become loose early.
Yeah.
So those are the things that are meant to be looked into to decide what should be done next.
A lot of questions coming in, and I have two more here. In terms of arthritis management, somebody here is asking, can it be completely cured with early intervention?
No, not quite. As I said to you, the articular cartilage, as I showed there, once it degenerates, you cannot reverse it. There are now advances in the treatment where we're talking about autologous chondrocyte implantation, where you harvest your own cells from the articular cartilage, grow them in the lab, and put them back. So those are the things that are being done now. And there's a lot of research into stem cell to intervene before it gets to a point of wear and tear. So that is the direction that the research is going into. But I must say, once there's established arthritis, it is not curable, but it's manageable using what I've shown today.
Right. Another viewer here saying, what are some home remedies for arthritis pain? We're now talking away from medication, away from prescription drugs, the home remedies that would help with this discomfort.
We say top on the list, watch your weight. I think we have to say that obesity, we're talking of obesity, not just obesity. Second thing, diet. We have to include even people with gout. We say avoid red meat, go into, and black beans, go into white meat, and increase hydration. That's the other thing that I needed to mention, that drink more fluids and exercise more, and take white meat for the gout. The others, maintain a level of exercise, and if there's some pain, then manage it with some painkillers in the early stages. Right.
In terms of the flare-ups, which we had talked about being people living in cold areas, Mount Kenya, just the colder areas of the country being more prone to flare-ups, how can you prevent a flare-up?
Keeping warm is one of the main things that we tell them, especially the patients who get that flare-up when they're in the farm. So we tell them use leg warmers, use gumboots, because we know that when they get exposed to the cold, especially the hands, use gloves, because that keeps that stops the pain coming back, the flare-up.
And as we begin to close, Dr. Hari, in the country, based on some reading that I've done, there seems to be a higher prevalence of arthritis over the years, and you know, this, of course, is very technical, and perhaps you stand better in terms of advising us. Previously, like I said, it was more associated with the older population. What would you attribute to the higher prevalence, to the rising numbers in terms of the diagnosis, and it just now moving away from the older population to perhaps pediatric cases, women, and even perhaps the whole gender issue that we've talked about, the menopausal women, in terms of numbers going higher? How can we manage this from becoming a public health concern in the country?
We've said that the numbers are going up because of different reasons. And even may just go back to the 5 types. You said osteoarthritis, we said there's rheumatoid arthritis, septic arthritis, post-traumatic arthritis, and I would say gout. If you look at gout, it is a lifestyle disease. A lot of people are going to the middle class, they're able to afford what I said, the causative factor, cause and link. When you look at rheumatoid arthritis, it is about better diagnosis. So we're now able to diagnose more. People are making contact with orthopedic surgeons and rheumatologists earlier, so they are able now to make that diagnosis. When it comes to septic arthritis, it's all about early diagnosis. Yeah. That's why one of the reasons why the numbers are going up. But above that, the lifestyle, especially obesity, is also on the rise, and that is global, not just here. So those are some of the reasons that we think globally and also locally arthritis is on the rise.
So away from the gout, in terms of arthritis and gout and the red meat and the high alcohol intake, what role does diet play overall in managing arthritis?
I would say diet, balanced diet is what we are looking for. And balanced diet, we mean maintaining what should be the constituents of a good bone, and to talk about calcium intake. I also should mention that in the early stages of arthritis, some supplements do work, and we know that that has been studied over the years. Taking things with chondroitin, sulfate, or glucosamine help nourish the joint surfaces, and also the big story about synovial fluid. So those supplements do work. But I must emphasize that balanced diet is about maintaining the health of the bone and the health of the joint. Yes.
And as we close, your parting remarks around arthritis and its management and prevention.
I would say that arthritis is a manageable condition. One needs to make the right diagnosis at the right time so that you can initiate that management early on. And among the 5 types of arthritis that I've talked about, all of them can be managed and people can live normal life as expected.
Dr. Michael Maru is a consultant orthopedic surgeon. He has walked us through arthritis. Thanks so much for finding time to be with us this morning. My name is Lillian Muli. Enjoy the rest of your viewing.